from the USA. And it is not that they are sending only to UMSA, and they are having their own database called FAERS, FDA Adverse Event Reporting System. And they are using this method, EBGM method, to identify the signals based on whatever the report they are generating in a USA, EBGM. So these are the four important, if you don't remember any other things from this session, at least you remember there are four important, there are so many other methods are available for signal detection quantitatively, but importantly, there are four which are commonly used by everyone in all the countries. Basically, we can divide them into two: disproportionality and Bayesian measures. Under disproportionality, we are having proportional reporting ratio and reporting odds ratio. And under the Bayesian, we are having the information component, which is following by the UMC, Uppsala Monitoring Center, and the EBGM, that is an empirical Bayesian geometric mean, which is mainly following by the US FDA. If you remember that much, at least from this session, it is fine for you. Maybe later on, you can understand more about the signal detection. So we will go and see quickly like how exactly we are going to perform the calculations whenever you take up any new hypothesis, either this medication can cause this reaction or not, and how you are going to be identify the signal, right? So this is one of the latest paper we have published in the International Journal of Clinical Pharmacy on SGLT2 inhibitors, that's a sodium glucose co-transporter 2 inhibitors, and the novel class of anti-diabetic medications. Either they can cause pancreatitis or not. And then we have gone for the signal identification by performing the disproportionality analysis of the spontaneous reports, whatever they have reported in the US FDA adverse event reporting system, as well as in the VG base, as well as in the Canadian adverse event reaction database. So we have taken all the three databases and try to identify the signals between the SGLT2 inhibitors and pancreatitis. And interestingly, what we got to know is this medication. So there are currently 4 medications under this classification, starting from canagliflozin, dapagliflozin, and empagliflozin, and recently we have etugliflozin. And all this medication overall are reported to cause pancreatitis, and the signal is identified between this medication as well as pancreatitis. And this was not listed currently under the product information leaflet. The pancreatitis, there are so many other reactions they have reported in the PIL that this medication can cause, but not exactly the pancreatitis. And that's the reason we have taken up, and then we have seen that are there any signals identified between these medications and pancreatitis. So how exactly we are going to be calculate the signal? I'll spend some more time, like 5 minutes, just to explain to you how exactly we are going to be calculate the signals in pharmacovigilance. It's very easy, not a complicated one. People will be thinking that signal detection is one of the complicated topic, but it's very easy if you understand the concept. Like what exactly we are going to be do here is, let's say, for example, we have this many reactions in the database, all the reactions, irrespective of the medication, irrespective of the reaction, we have this many reactions in our database, right? And out of this many reactions, let us say there are 110 reactions on empagliflozin. Empagliflozin is one of the SGLT2 inhibitor. Out of all the reactions what we have in the database, 110 reactions are reported on empagliflozin. And out of this 110 reactions reported for empagliflozin, there are 5 on the event of interest, the reaction of interest, that is pancreatitis. Okay. So out of 110, there are 5 related to pancreatitis, and remaining 105 related to all other reactions. Apart from pancreatitis, there may be so many other reactions reported for empagliflozin. So 105 are all other reactions and 5 on pancreatitis. Okay. For the empagliflozin, and total number of reactions are 110 out of this around 4,79,000 reactions available in the database. Okay. And apart from that, apart from empagliflozin, there may be so many other medications in the database, and we will understand that what is the total number of reactions for all other medications except empagliflozin. And out of these numbers are there for all other medications, how many on pancreatitis and how many on apart from pancreatitis, like all other reactions. So basically, for this is the information about medication, empagliflozin and all other medications. And this one is about reaction, pancreatitis, and all other reactions. So we are going to be understand what is the exact number, including the total numbers. Okay. So now we are going to give the coding here. It is almost similar to if you know about calculation of relative risk odds ratio in the pharmacoepidemiology. it is almost similar to PRR and ROR in pharmacovigilance. Like we are going to be give the coding A, B, C, and D, and this one is A plus B, and this one is C plus D. We are going to be give some coding, and from this we are going to be calculate by using very simple formula. We are going to be calculate the PRR and ROR. Very simple formulas you can easily remember. Like we are going to be calculate the proportional reporting ratio. It is very similar to the relative risk what we have in the pharmacoepidemiology, proportional reporting ratio. And very simple formula, it is A by A plus B divided by C plus D. So it is nothing but like a proportion of reactions of interest for the empagliflozin compared to the proportion of reaction for all other medications. So proportion means 5 divided by total number of reactions, 110. And for all other medications, 53 divided by 479515. That's what we are going to do under the proportional reporting ratio, PRR, A by A plus B divided by C plus D. And the other one we are having is a reporting odds ratio, ROR. So how we are doing this reporting odds ratio is, once again, it's very similar to the formula of odds ratio in pharmacoepidemiology. It's just a cross multiplication. Like either we can have A by B divided by C by D. That's a formula, actual formula. And we can also write like this, like A by A into D, cross multiplication, A into D divided by B into C. So we can have that cross multiplication as well for this reporting odds ratio. So these are the like how we are going to get the numbers in 2x2 table. So once we have these numbers in 2x2 table, we can easily calculate the signal by using the PRR and ROR. I'm not showing the IC here. IC is we are going to be use a complicated formula for calculating the information component, but very easy way to calculate is a PRR and ROR by using these simple formulas. So once we incorporate all these values in the formula, like PRR, the value what we got here is 411. Along with that, if you apply the formula for chi-square by using these 4 values, we can get the chi-square value as well. So chi-square value here is 1870.1. And the reporting odds ratio, if you incorporate all the values here, and ROR, what we got is a 430.8. Along with the confidence interval, we can get, once again, if you use the formula for the confidence interval. I'm not showing all the formulas here, but you can calculate either by using the formula, or if you keep all the 4 values in any software, even the online calculator, you're going to get the chi-square value as well as the 95% confidence interval. No need to bother much, and you're going to get the confidence interval. So now we got these values, like we got the PRR of 411 and ROR of 430. They are the huge numbers. We can say, like, usually RR and OR, we are going to see 1, 2, 3, 10, something like that. But here you can see that the PRR is 411 and the ROR is 430. So how to understand the signals? Like now we got these values. Like, can I say that the signal is identified between the empagliflozin and pancreatitis, like whatever the values we have taken here? Based on these values, can I say that there is a signal identified between empagliflozin and pancreatitis or not? And how I'm going to say that is, there are some standards for this. Once you calculate all these values, there are some standards we need to follow. And based on the standards, we are going to say that either the signal is identified between the drug and reaction. So the first thing, maybe you can note it down, these things, because they're very important. Because without these standards, we cannot understand that either the signal is identified or not. And the PRR value, first, for example, once you get the PRR value, by using the PRR, we are going to be identify the signal if the count of co-occurrences more than 3, and the PRR value more than 2, and the associated chi-square value more than 4. So all the 3, whenever applicable, like whenever we get all the 3 satisfied, we can say that signal identified between the drug and reaction by using the PRR. The first one here, it is the count of co-occurrences more than 3. The meaning of count of co-occurrences more than 3 is the number of reactions identified till now exactly on empagliflozin for pancreatitis, that is A. So here, this number should be more than 3 at least to say that the signal identified between the drug and reaction. So this number should be.
Sorry to interrupt, Krishna sir.
Yeah.
Sorry to interrupt, Krishna sir. Our next speaker is on board, so I would request to conclude in half.
Yeah. I'm concluding in just two minutes. Yeah. So we are going to get the PRR value, and if it is more than 3, and at the same time PRR value more than 2, at the same time chi-square value more than 4, we can say the signal identified between the drug and reaction. Similarly, for ROR, reporting odds ratio, along with the reporting odds ratio, we are having the confidence interval, 95% confidence interval, right? So whenever the lower limit of 95% confidence interval exceeding 1, we can say the signal identified between the drug and reaction. Similarly, when you go and calculate the information component IC, I did not show you here, but we can calculate by using the formula which is given by the UMC, Uppsala Monitoring Center. So when you calculate the IC value, information component value, once again we are going to have the 95% confidence interval for the IC, and in that there will be a lower limit called IC 025, information component 025. Whenever that exceeds 0, we can say that signal identified between the drug and reaction. And the last one is EBGM. Once again, I did not show you this because it is mainly calculating by US FDA by using some of the complicated theory. And whenever they calculate the EBGM, easy way to understand is whenever the EBGM value is more than or equal to 2, we can say that signal identified between the drug and reaction. So these are the 4 important methods and 4 important standards we are going to be follow whenever you want to say that signal identified between the drug and reactions. So that's about basically the quantitative way of understanding the signals. And it's very, I mentioned to you like very easy way, but the signal detection is not that easy. There's a complicated process we need to follow for a longer period of time. But at least you may got some basic understanding from this presentation. Thank you very much for your kind attention.
Thank you, Dr. Saab. Thank you so much for your understanding and knowledge for signal detection. And NIMS University is thankful for you for getting time to schedule. Thank you so much, sir.
Thank you. It's my pleasure to be part of it.
Thank you so much. Sharing, Krishna, sir. Your screen.
Yeah, I think I already did it. Yeah, I stopped my screen share. Yeah.
Forward, yes. Thank you so much, Krishna sir, for joining. Next, we have Dr. Pratibha Singh with us.
Dr. Kose,
Thank you so much,
can you
Dr.
make Dr. Jaipalan as a co-host?
Yes, sir.
I think he has connected. Not now.
Next,
So
moving forward, we have Dr. Pratibha Singh. Yes, sir. Thank you, sir. Next, we have Dr. Pratibha Singh with us. Dr. Pratibha Singh is Master in Public Health with specialization in epidemiology, University of Alberta, Canada. Dr. Pratibha Singh is presently Master's Public Health with specialization in epidemiology at University of Alberta, Canada. She is a PharmD alumnus of NIMS Institute of Pharmacy, NIMS University, Rajasthan. Although she has a research history in working closely in the field of clinical research, especially in liver-related conditions. Dr. Singh's recent work is focused toward the intersection of infectious and pharmacoepidemiology and its associated public health surveillance. Apart from the core academic work with her in interest in addressing the challenges of the status quo, she has developed policy recommendation for violence against women for and mental health illness in Albertans. With this short bio sketch of ma'am, I would like to call Dr. Pratibha Singh to open the mic and start presentation. Over to you, ma'am. Dr. Pratibha, can you hear us?
Yeah, I can hear you, Dr. Kose. Can you hear me now?
Yes, ma'am. Yes, ma'am. You are very audible. Please start.
Are you able to check on my screen now?
Yes, yes.
Just a minute, ma'am.
You can call me Pratibha. Please don't call me ma'am.
Yes, you can share, ma'am. Start, please.
I have already shared.
Yeah,
Me.
your screen, your sharing is screen is visible. You can start.
Cool. Yeah, thank you for such a warm introduction, Dr. Kose. As Dr. Kose said, my name is Pratima. I'm an alumni of NIMS University. I completed my PharmD and I graduated in year 2020. Presently, I'm pursuing my master's in public health with a specialization in epidemiology at University of Alberta. So I understand that the purpose of this whole workshop is to talk about pharmacovigilance, but at the same time, I also think that we do know pharmacovigilance in bits and pieces through a number of resources available on a web or Google, right? So my whole perspective of choosing this topic on epidemiology and clinical research was more so related to bring the perspective of pharmacoepidemiology in the budding pharmacist, what we have at NIMS University or in general in India. So before starting my presentation, I have a quick question to the audience. I don't know how many people are listening to me right now, but what do you guys think on the best evidence from which we can actually report best type of study? I'm not sure if anyone is going to answer, or if anyone right now in the Zoom meeting can answer, would be awesome. It's okay. So I think as per my understanding, we have been taught that there's a hierarchy of level of evidence, and systemic and meta-analysis stands at top when we talk about the level of evidence in general in clinical research or in medical research, right? But in the real-time scenario, I think the dynamics of conducting these studies and generating evidence varies. How I think most of the clinical research or most of the type of research what we conduct is based upon what our clinical research question is or what policy we are exactly recommending. And that's what the research question decides our evidence of the study. So the best evidence is usually found in a clinically relevant conducted study, right? When we have a very sound methodology, we'll have a good study for sure, right? So that's how I believe good research can be conducted. A research in which we have minimized the bias is the good study. And in the search of that, I ended up pursuing epidemiology. And epidemiology, basically what people think about epidemiology, when I tell my friends that I'm pursuing epidemiology, they think that, I'm doing some very sound research where I'm just going to make some vaccine to mitigate Zika virus. My parents think that, I'm doing something really brilliant that as a research assistant at University of Alberta, that I'm going to contribute back to the society or back in India. Society think that, I have a solution for update for all the vaccine what we have in the market. But the dynamics is completely different. I think how I started my epidemiology journey was in the whole experience when I was doing my PharmD, where I always thought that, we do not have enough resources, or I have seen struggle during my hospital posting where people could not afford treatment, right? And that is the harsh reality. Maybe we won't talk about it, but that is the reality. There is a marginalized society in India which cannot afford the treatment. So rather than addressing that treatment, my quest was always to address why we have those risk factor which is growing now and then every time, and I always wanted to understand those dynamics well, and that's how I ended up to pursue epidemiology. So I think most of the fifth year PharmD students or all the pharmacy students know what epidemiology is, right? We talk about understanding a risk factor as in coffee cons coffee causes pancreatitis and stuff like that. But when I started pursuing epidemiology at 𝐄𝐴, I understand, no, it's not just about risk factor. It's not just about prevention. It's not just about understanding what is the incidence and prevalence of diabetic mellitus or cancer or whatnot. So epidemiology is one thing I think we as a pharmacist should really talk, because this is something which is going to take us a long way from the learning what we do in general in PharmD or in other courses of PharmD. I think people come reaching out to me, my juniors, that ma'am, I am interested in research, and I always have this quest that what kind of research are you actually looking for? And I understand I also didn't have those answers, but with time and with learning, gradually I understood that what I was looking for back then in 2018 or 2019, and I didn't have answer. So the whole purpose of coming up with this presentation was to share what I learned from the 2 years of journey at 𝐄𝐴, and how we are going to make a change from this learning, or how we as a pharmacist can going to make a change through what we are learning in general right now, except those dynamics of what we say hospital pharmacist or clinical pharmacist, is through epidemiology and going forward with pharmacoepidemiology. Since I joined this presentation, I think Dr. Undela talked a lot about pharmacoepidemiology, and I think he was the first person when I looked up to, and when I wanted to understand pharmacoepidemiology, I think it was just Dr. Undela's research in India which I looked up, and I understood bits and pieces of pharmacoepidemiology. So it is a less talk stuff. We talk about pharmacovigilance now and then every time, but we don't know where exactly are we going to implement that. And that was the struggle. I was always understanding why we want to understand pharmacovigilance, but I didn't understand how we are going to make a difference with what we are learning in 6 years through pharmacovigilance and then through pharmacoepidemiology. So moving forward, epidemiology is one of the very powerful tools. When you know epidemiology, you have those skill set to understand what is leading to what exposure. Let's say if you're smoking, just for example, how in the time being you're going to end up having lung cancer, right? And that's why we talk every time now and then about study designs, talking about case control study, cohort study, and whatnot. And I think risk factor, odds ratio, back and forth in our curriculum, right? We do study those things, but where do we apply those things in our hospital posting? No. And I think here is the need, right? Why we don't apply is that we do not have a sound knowledge of pharmacoepidemiology. I didn't have, and I considered that I was I had this quest while I was pursuing my PharmD to understand what I'm learning from all those 3 years of pharmacology, how I'm going to apply it. And the things ended up talking about, you're going to a hospital posting and you'll end up being a community pharmacist or whatnot. So I think pharmacoepidemiology is something which is a triad of clinical research, clinical pharmacology, and epidemiology. This whole thing clubs, and then we understand pharmacoepidemiology. And to understand pharmacoepidemiology, we have to understand that there is a difference between all these three terminologies. We do not have a proper understanding that we do know clinical research is all about clinical trials. Clinical pharmacology is all about pharmacokinetics and dynamics, but we don't know how we are going to club those knowledge to bring up to a real-time scenario, which is pharmacoepidemiology, right? Because it's all about why PharmD was introduced. It was introduced because we wanted to address those adverse drug reaction. We wanted to address those concerns, what we have for medication error, polypharmacy, and what Dr. Undela talked about, right? Those signal detection management and whatnot. But is that those things being addressed? The real-time answer is no. And so now when I look back and I think why we don't have those solutions, we have everything, but still we don't have a way where we should know how we are going to address those solutions. And learning the skills what pharmacoepidemiology teaches us is going to have those solutions, be it in the job market, be it if you want to pursue a research based career ahead in PhD. But I feel pity when people only talk about drug utilization study and they don't understand that, there are many more paradigm of pharmacoepidemiology. So going ahead, why I say it is important. So we know about randomized control trial, right? But there's a harsh reality of randomized control trial. We always have a very titrated inclusion and exclusion criteria. Whenever you look back and whenever you will see how these studies are conducted, they are titrated in such a way that it is not real world scenario. When a patient in India is coming up in a hospital, you will not have those specific inclusion and criteria. And if you don't have those, it is not a surety that the drug is going to act right. So we do conduct randomized control trial, and then we do have those safety endpoints, which what we have taught in clinical research, right? That we'll do safety studies and whatnot. But then there is a reality. The studies are very short term, right? We have an intent to treat analysis method where we exclude safety. We do not talk about safety. So those are the harsh reality of clinical trial in general. There are a number of benefits for sure, but then there are these two harsh realities. And that's why when it comes to a country like India, which is a populated one, we cannot apply those studies in the real-time scenario, right? And when we cannot apply those, we'll have hard time understanding how we are going to address those adverse drug reaction. I know we have been talking from 2005, I think 2014, I started my PharmD, and we've been talking about, we have ADR monitoring center and whatnot, and those are good for sure. We are progressing for sure, but where are we right now? No, we have not traveled a big way and a long way, right? Because understanding adverse drug reaction is something really complicated. It's not every time easy that, you'll have a patient of tuberculosis, you'll have isoniazid, you will run your software such as Clinirex, and you'll have the output. No, you need a proper skill set. And every time we do not have that, because we are oriented to understand drug. We are not oriented to understand the clinical dynamics. And I think in history, we know how the whole journey of adverse drug reaction started, right? So we do this spontaneous reporting. We talk about adverse drug reaction. And the good part of adverse drug reaction is that it's a quick reporting system. We have a database, and there is a whole dynamic. When you do a quick Google search, you'll see we have AMC, north, south, east, west, and then we have this method of CIOMS where we are generating those data. And yes, it is impactful, but then there are many things which are not measured from these spontaneous reporting. We do not have the exact rate of events, because we cannot lie that we are not reporting in a exact manner how it has to be. I will take 2 more minutes, Dr. Kosha, and then I'll conclude. We do not have exact data to address delayed and long-term effect or small and moderate risks. So we do have spontaneous reporting, but then there are some lacunas, right? And there we can bring pharmacoepidemiology in picture. When we talk about pharmacoepidemiology or epidemiologic study, it counts those observational study, which you can see in the slide, about cross-sectional study, cohort study, or case control study. I know in 5th year research, Dr. Manning is coming up and he's going to talk. He has a number of research related to more so on observational studies and whatnot. But the problem is that we cannot use those data what we have in hospital to report those real-time pharmacoepidemiology output. Why? Because we do not have a proper organized system where we can have such research of having a primary database of how the medicine was prescribed at the hospital, how it was linked to the clinic where he took the treatment. So all those claim database, what those advanced country has, what Canada has, what let's say maybe UK has. So we do not have that. And these awesome research, what you can see on the screen right now, we cannot do such research. And this is pharmacoepidemiology in general. Understanding those risk factors, understanding those drugs which are actually on the long term, like is causing adverse drug reaction. We do not have that. And I think I do not have an answer how we can have those database. But I also understand that when we conduct the research in our 5th year, if we can work around to have some stabilized system to conduct those database, to have our investigator which can help us to have those database which you can see on your screen, right? Where we can utilize your pharmacy in hospital properly to use those patients which are coming to your pharmacy, checking back, using those records can actually make a long-term impact. So yeah, I do not have the real answer how we are going to bring those, how we are going to use administrative database in India. We do not have that, yes, but then I really know that a brilliant person like Dr. Undela can guide you all folks to have something, maybe me on the longer run, but I really think we should conduct these studies. We should use our drug registries. If not, then we should use our pharmacy in general to conduct such studies to have a real-time impact. And that's how we can stand by to decrease adverse drug reaction or side effect. So that's all from my end. Thank you for listening me. And thank you, Dr. Kose, for the patience. I took 2 minutes extra, and sorry about that.
Wonderful presentation, Dr. Pratima. It was a pleasure having you on board. And really, you touched on to the major aspects in major research areas of pharmacy practice and clinical research. Thanks a lot. Since this session was YouTube live and we had audience pan India watching this, I will share to you. And thank you so much for joining. Next, we have, thanks a lot. Next, we have Dr. Manik with us. To read out his short bio sketch, I will take just 1 minute. Yeah. Dr. Manik 𝗥𝗲𝗴𝗶𝘀𝗁 is currently a PhD candidate, research scholar, Department of Pharmacology and Therapeutics, Winnipeg, Canada. Dr. Manik is alumnus of ISF College of Pharmacy, Moga, Punjab. He did his PharmD. Dr. Manik has published more than 50 research and review articles in international journals of repute. His research areas are pediatric clinical trial designs, drug safety, patient engagement in clinical research, systemic literature review, and meta-analysis. During PhD, he has won several awards such as Dr. Mark Nickerson Entrance Award in Pharmacology and Therapeutics, International Graduate Student Entrance Scholarship, Research, Manitoba, and George Fay Center for Healthcare Innovation, CHI, partnered doctoral fellowship as well as 𝐄𝐧𝐿 Family Scholarship Oncology Report. With this short introduction of Dr. Manik, I would like to invite him. Dr. Manik, please start your presentation.
Good morning, everyone. Thank you, Dr. Kose, for a warm introduction. So today I'll be speaking about the pharmacovigilance case studies. So before I proceed, I'll just give a brief introduction about myself. I did, as Dr. Kose just briefed about me, I did my PharmD from ISF College of Pharmacy. Then I worked as an ICM research assistant in the Department of Pharmacy Practice, Jaipur, Mohali. And currently I'm a Ph.D. candidate in the Department of Pharmacology and Therapeutics, University of Manitoba. And I love to play basketball, explore new places, and do a lot of reading. So learning objectives for today's presentation is I'll just give you a brief about the glossary terms before I dive into pharmacovigilance, then brief about pharmacovigilance, why ADRs are important, then type of adverse drug reactions, ADR detection flowchart, then case report 1, case report 2, just to give a glimpse for this workshop, then prevention of adverse drug reactions, role of pharmacists, and research perspective. So glossary terms, these terms I'll be using while walking you through the published case reports. For these glossary terms, if you see what is adverse event, adverse event is unexpected medical problem that happens during drug treatment or any other therapy, and it doesn't mean like if any patient is suffering from any adverse events, it is related to drug, can be related to some comorbidity. And further, we have adverse drug reaction. Adverse drug reaction can be defined as unappreciably harmful or unpleasant reaction resulting from an intervention related to use of medicinal product. Then causality assessment. Causality assessment of adverse drug reaction is a method to estimate the strength of relationship between the drug exposure and occurrence of adverse reactions. Further, we have temporal relationship. It is time relationship between drug administration, date of therapy, start date, therapy duration, and occurrence of adverse event, mainly event onset, date of initial symptoms observed. Further, if I talk about pharmacovigilance, pharmacovigilance is a science and activity related to detection, assessment, understanding, and prevention of adverse effects or any other medicines or vaccines related problems. And further, why pharmacovigilance? It is important for identifying the new information about the hazards associated with medicines, preventing harm to the patients. If we talk about this pharmacovigilance, like usually the milestones for the development of any drug when it comes to market, like it goes through preclinical studies, clinical trials, and then pharmacovigilance. But in case of clinical trials exclude the patients with multiple comorbidities. Then again, they exclude the patients with lower age or higher age, like mainly pediatric and geriatric patients and pregnant and breastfeeding women. So we need to determine the safety of any drug product which is in market based on the real world evidence. And there comes our pharmacovigilance, which helps us in strengthening those evidences. And so adverse drug reactions. Why we are studying adverse drug reactions? They are major burden on healthcare system. Approximately 3 to 5% of hospital admissions are related to adverse drug reactions. And additionally, 5 to 8% of the all hospitalized patients experience serious adverse drug reactions. Further, 5 to 10% of the hospital costs are related to adverse drug reactions. And these are some of the drugs which were withdrawn from the market because of their adverse drug reactions. And if we see how adverse drug reaction is detected, and mostly if I can see audience pool is clinical pharmacists, they are budding clinical pharmacists. So if you are administering, if patient is administering any drug, and then further, if you see patient develop a new condition or symptom, which is adverse event, as explained in my glossary terms. Further, if you see, is there any suspected drug for that particular adverse event? Yes, then again you dive into, just check into the literature, you check into the drug information resources, you can check into the secondary evidence, you can explore if any pre-existing systematic reviews and meta-analysis on that topic. And then further you can see if there are any documented cases of similar class of drugs. Then at last, like you can say this is highly suggestive of adverse drug reaction. But before this, we need to do a lot of other things, like we need to determine the causality, whether this adverse event is really related to that suspected drug, which we will convert that adverse event into suspected adverse drug reaction. And further, if we see adverse drug reactions, I'll just dive into only 3 basic adverse drug reactions, won't go more deep into the types, just to make you guys clear about the theoretical concepts behind those case reports which I'll be discussing. So if you see type A, which is augmented, and type A type of adverse drug reaction is related to pharmacological action. It is dose dependent and predictable. So with increase in dose, that particular adverse event will be increased in the frequency and intensity. And if we see examples for this, postural hypotension with alpha adrenergic adrenoreceptor antagonists like alpha blockers like prazosin, trazodone. Then we see bleeding with warfarin. Warfarin is an anticoagulant. Then sedation with anxiolytic drugs. Further, bizarre reactions, type B. Bizarre reactions, these are type B adverse drug reactions, which are mainly due to idiosyncratic reactions because of abnormal physical reactions by individuals to food or drug. They are different from pharmacological action of drug, like aplastic anemia from chloramphenicol. Like there was hypersensitivity reaction patient who was taking chloramphenicol, and they found the patient got like aplastic anemia. Then we have anaphylaxis in response to penicillin, which is allergy. This is based on the genetic history. Like there are certainly enzymes like HLA-B4s involved, which causes that adverse drug reaction. And then again, this induces immune response and can be prevented by genotypic screening. And then we have C, chronic reactions result from chronic use of drug, well known and accepted, like tardive dyskinesia with prolonged use of antipsychotics. And like some patients do suffer from ataxia due to chronic intake of phenytoin, nephropathy with NSAIDs. So here comes our main case report. So as session is mainly a workshop session, so I'll be discussing a case now, real-time case. Like a 55-year-old man bearing a weight of 60 kg, he was presented to outpatient department with chief complaints of repeated suicidal thoughts, joint pain, restlessness, depressed mood, constipation, insomnia, tinnitus, and decrease in hearing sensation from past couple of weeks. He started taking anti-tubercular therapy. So here he suffered from suicidal tendency, which is a take of like that's adverse event, decrease in hearing sensation. Then he was again based on his medical history, he was a known case of multi-drug resistant tuberculosis, and past medication history revealed that he was adhering to category 4 DOTS therapy. DOTS is a therapy used in India for tuberculosis. DOTS stands for direct observed treatment short course. Then if we see the regimen, DOTS, like we have different classes of drugs like ethambutol, pyrazinamide, ethanamide, kanamycin, cycloserine, levofloxacin, and pyridoxine, which were prescribed to the patient. So based on this treatment chart, are there any thoughts which drug can cause this adverse drug reaction? So hearing loss. So can anyone predict this hearing loss? If anyone from Zoom would like to jump in. But anyways, so if we see this drug chart, hearing loss is side effect of aminoglycosides, which kanamycin in this treatment chart is aminoglycoside, and this hearing loss was associated with kanamycin, and then suicidal tendency, it was associated with cycloserine. And how we rule out this in real-time scenario while discussing with the patient, like patient history, he had complaints of reduced sleep with anxiety and repeated suicidal thoughts immediately after 2 days of intake of suspected medication. And on diagnosis, he had a complaint of bilateral decrease in hearing sensation with the ringing of bell in his ears. And we took opinion from otolaryngologist, and he was diagnosed with bilateral sensorineural loss of hearing, and then further he was diagnosed with drug-induced suicidal tendency. Then again, we found out some literature, and we found that this particular drug is associated with that, and like will lead to drug withdrawal. And psychiatric consultation was done for that patient, and he was prescribed with quetiapine 25 mg per oral, and cycloserine was suspected, and we stopped cycloserine immediately at that time, and dose of kanamycin was reduced to 1 gram to 750 mg. And then soon after 2 days of withdrawal of cycloserine, the dose of kanamycin was also reduced, and patient's suicidal thoughts disappeared, and he was like his hearing loss complaint and this subsided. And again, after 3 days of patient, like he himself took that cycloserine again, the fear of tuberculosis relapsed, and his symptoms again aggravated, and there was readmission of that patient. So this means, like, further we also did WHO causality assessment scale, like it determines this causality between the suspected adverse drug reaction and the drug, which was cycloserine and suicidal tendency, and adverse drug reaction was found to be certain, and further for hearing loss and tinnitus, it was found to be probable. And we published this in the current drug safety journal, Bantam Sciences. Further, if we see another case report, a 30-year-old male patient was presented to psychiatry department with primary diagnosis of paranoid schizophrenia. He was on tablet haloperidol and developed was given twice a day, and he was non-responsive to current regimen, and there was change in his behavior. Like he was treatment resistant to this treatment which he was receiving, like I can say 5 years or 6 years back, and further he was initiated on tablet 𝗥𝗲𝗴𝗶𝘀𝗁 so that we can get him back to his normal life. And dose was 12.5 mg. Later on, dose of 𝗥𝗲𝗴𝗏 was titrated up to 100 mg a day. Like we usually for 𝗥𝗲𝗴𝗏, it's a dose titration which starts with the lower dose and keep on increasing. And then developrex was also given. Dose was 500 mg. Then on day of hospitalization, when patient was started on 𝗥𝗲𝗴𝗏, he experienced sudden fall. His vitals were monitored, pulse rate was irregular and irregular heartbeat, and his blood pressure was fluctuating. His heart rate was 95 beats per minute, and his blood pressure was quite low. It was 100/60 mmHg. And then patient complained of substernal pressure, palpitation. Then again with the residents, we went to neurology physician to have a second opinion. He was not having any seizure disorder. He was ruled out for seizure disorder and acute coronary syndrome. Then Holter monitoring was performed. And so over here, based upon his medication history and current treatment, what do you think? Like what was the cause for arrhythmia, which was ventricular ectopics? So I thought this session would be interactive, but still I'll go on. So 𝗥𝗲𝗴𝗏 was responsible for that, and how we ruled out. When 𝗥𝗲𝗴𝗏 was withdrawn, patient symptoms subsided. He became medically stable on day 5. 𝗥𝗲𝗴𝗏 was found to be culprit for the adverse drug event, and WHO causality assessment was also performed. Then ADR was found to be probable, and severity of ADR was on level 5. We did severity also with heart-wing severity assessment scale, and these were the Holter monitorings. Like his maximum beats were 135 and all, and frequent PVSC present episode of ventricular tachypnea was noticed, and like the monitoring was started at 940 and heart rate was 750 beats per minute, and then this went on. Further, we published this in Journal of Basic Clinical Physiology and Pharmacology as a case report. So then here comes your role as a clinical pharmacist, how you can prevent adverse drug reactions. Like we can avoid inappropriate drug use appropriate route, dose, and frequency, consider previous history of drug use, perform genotyping in case of long-term use of drugs, especially to avoid type B of adverse drug reactions, avoid drug interactions, perform appropriate laboratory monitoring. Like some drugs are associated with increase in LFTs and they can deteriorate renal function tests. We should perform regular monitoring, and then again administer drug in the form of right administration technique, like slow dose of vancomycin, which can prevent adverse drug reaction related to vancomycin. Again, main role being a pharmacist, like you can actively participate in ADR reporting. If any ADR you come across during your ward rounds, you can document that, you can publish that, and that will increase your education credentials. And further, you can consult patients on adverse drug reactions and its prevention by 4 Rs, like right dose, right route, right administration, and rule out drug-drug interactions. Like you can always evaluate the treatment chart for drug-drug interactions, suggest genotypings for HLA, like gene for preventing type B adverse drug reactions. Specifically, if you see the drug allopurinol, which is used in hyperuricemia, gouts and all. So if you perform HLA-B for genotyping, you can, if patient is susceptible, you can prevent Stevens-Johnson syndrome and toxic epidermal necrolysis in those patients. Then again, monitor the progress of the patient, listen to him for early detection of adverse drug reaction. And then again, maintaining the patient records, participating in the evaluation of drug therapy will give you exact idea, and you can easily detect, and you can participate in spontaneous reporting, which usually is like under the pharmacovigilance program in India. Further, if you see about the research perspectives, you can follow a PICO approach, PICO stands for Patient Intervention, Comparison, Outcome, and Study Design. And you can conduct systematic literature review and meta-analysis to generate evidence on drug safety. You can participate in pharmacoepidemiological studies, generate primary data on adverse drug reaction monitoring. Always vigilant if you observe any adverse drug reaction, that always you can report to ADA reporting center, as well as you can publish in the form of case report. And if you're getting series of the cases, you can publish as case series, and always actively participate in spontaneous reporting. Provide healthcare providers with unbiased drug information, including adverse information related to adverse drug reactions, related to information for drug-drug interaction. Then, as I told, PICO's approach, we published a systematic review where we evaluated the left tiracetam-induced cutaneous reverse drug reaction. And this was like work which we did for spontaneous reporting. And then this is another systematic review, and these were some case reports. The session is open for the questions. Thank you.
Dr. Kosei.
Thank you so much.
Thank you so much, Dr. Manik sir, for giving us insight about the case studies which you have provided, sir. Thank you so much. Now over to Dr. Saurabh sir.
Thank you so much. Thank you so much. All that would like to thank especially Dr. Pratim and Dr. Manik, since it is 7:30 p.m. and delivered to all of us. So again, thankful to Dr. Pratima and Dr. Manik, and a special mention to Dr. Undela, since he is in South Africa for one conference. Still, he accepted our invitation in time and is the function. So thank you so much for the first of this pre-conference on ADR reporting. And I'm thankful to all the viewers watching this online on YouTube. You may write your questions to us. Definitely, we'll put that questions to our speakers, and we'll connect you to with their the answers. So